been participating from last 3 months for our NNF Karnataka State Chapter Neo Master E-Class. Today we have got two wonderful speakers who have got rich experience, and their teaching is famous all over India, and most of them would have heard or been their student or heard from them. So this is the lifetime opportunity to hear from Dr. UMESH VAIDYA sir and SWARNA REKHA madam. And the best part is today's session is moderated by our beloved and most respected Dr. P.P. Mayes sir. So on behalf of NNF Karnataka chapter, on behalf of our entire office bearer, president, vice president, our joint secretaries, executive board members, and the entire NNF Karnataka family, we would like to give you a very, very warm welcome to you, sir. Welcome for the session, sir.
Thank you.
So today's topic is neonatal stroke and floppy infant. So I request Kishore Kumar sir to give a brief introduction about UMESH VAIDYA sir, and I request after that to start the session. Kishore Kumar sir. Over to you, sir.
Yeah, sorry, I didn't know that I was going to introduce him, sir. I mean, Umesh doesn't need any introduction at all, but I'm sure he's very well known everywhere. But for the junior faculty or junior members who are of younger generation, those who don't know him, Umesh is one of the leading neonatologists of the country, and is based in Pune. And he has done his MD Pediatrics from Pune. After that, he has worked for a few years in Australia. And he's instrumental in making the King Edward Memorial Hospital in Pune one of the best neonatal units in the country. And currently, he is in Cloud9 Pune. And he has written innumerable articles in various international and national journals and published few. And he is very talented. And of course, most of you probably have heard him about feeding. He's very passionate about feeding and avoiding extrauterine growth retardation in premature babies. But he's also very passionate about lactation, and he's one of the very few people who have gone and established human milk banking in Pune quite long back, which is a new concept in Bangalore, but he has done it long back. If I keep talking about all his achievements, I need 1 hour. I think that should be enough for many junior faculties. Over to you, Umesh.
Yeah, thanks, Kishore. And first of all, before I start this topic, I have to thank all the office bearers of Karnataka chapter, particularly President Dr. Koturesha, Dr. Kishore Kumar, Dr. Prashant, Dr. Bidri, Dr. Dinkar, and all other office bearers. I also have to thank again for giving a topic of neonatal stroke. I think when we attend so many different meetings and we attend so many conferences, we rarely get to listen to this topic, which is neonatal stroke, which is a relatively unusual topic. So I really compliment the organizers for choosing a topic which is a relatively common topic, not discussed so often in the neonatal fora. Now, why is this topic of neonatal stroke, why is it difficult? It's difficult because one is there are several case definitions. There's got a very variable presentation across age groups. There are several maternal neonatal risk factors. There's a battery of hematological tests, and we must know which to do and when. And the most difficult part is there are very few studies on this subject. And that is the reason why it's difficult to have evidence-based management and preventive strategies. And this is one area where it involves multiple specialties, including the neurologists, relatively a kind of difficult topic. Now look at the word that is commonly used now. They call it the ischemic perinatal stroke, or IPS. And very broadly speaking, it is a cerebrovascular event around the time of birth with pathological and radiological evidence of focal cerebral infarction. Now this is a very broad definition. It's mainly a disease of term and near-term infants, though preterm babies are known to have stroke. And the diagnosis is based on clinical symptoms, neuroimaging, as well as autopsy. Apart from this broader definition, let us go now to a very specific definition of stroke, especially which was laid down by Pediatric Neurology 2006. And it's a group of conditions. And every word here is important. There is a focal disruption of cerebral blood, secondary to arterial or venous, thrombosis or embolism, and this occurs in the perinatal period, that's between 20 weeks of gestation to 28 days of life, and it is confirmed by neuroimaging and neuropathology. So it has to be focal, it can be thrombosis or embolism, it can be arterial or venous, and it should occur in that particular age group. There are some things that are clearly excluded from ischemic perinatal stroke. Whatever is excluded, one are hemorrhagic events, like you have your subarachnoid hemorrhage or subdural. Those things are out of the scope of perinatal stroke. Generalized hypoxia, as we see in HIE, IVH related to prematurity, these are usually not considered part of neonatal stroke. We are looking at a focal disruption, either arterial or venous. Before I proceed further, I must introduce you to a few terminologies that are commonly used and the short forms which are written in the bracket, because we will be referring to them in the rest of the presentation. The terms used are arterial ischemic stroke or AIS, where there's a pattern of ischemic injury in an arterial distribution. The other word used is presumed perinatal ischemic stroke, which is seen in older infants beyond the neonatal period. And these focal deficits are related to a chronic infarction, which probably was missed in the perinatal period. And the third type of stroke is a cerebral sinovenous thrombosis, which is called as CSVT. So we are essentially looking at these three different terms. Managements are different, and during the presentation you will see these short forms which I will be using. The incidence reported is 1 in 4,000 in the neonatal period, but beyond 1 month the incidence goes suddenly to 1 in 30,000. So the neonatal period is the period when this is more common, but this incidence also is likely to be an underestimation because most of these babies are asymptomatic in NICU and stroke is missed. And we usually do an ultrasound in the NICU, and that is actually not a modality of choice when the baby is in NICU. So you're likely to miss many of these strokes in the neonatal period, and the actual incidence is likely to be on the higher side. So this is how we classify stroke: fetal, neonatal, and presumed perinatal. Fetal stroke is diagnosed on antenatal imaging and usually by autopsy. Neonatal stroke, two types: acute arterial ischemic stroke and cerebral sinovenous thrombosis, and the presumed perinatal ischemic stroke, which occurs later in infancy. Now, why is this perinatal stroke so different from that what we see in older children and adults? We know that normal pregnancy is a hypercoagulable state. The neonatal coagulation system is quite immature and more susceptible to clot formation. We have a placental interface, and I'm going to talk about it a little later. We have a highly vascular bed, and we have areas of low blood flow which can cause thrombotic lesions. There are several obstetric risk factors which we are going to discuss, mainly the thrombophilic mutations, and these thrombophilia may be present both in the mother as well as the baby. The point to remember is because mothers and babies are pro-thrombotic 48 hours before and 24 hours after delivery, when you want to measure these thrombotic factors in the newborn, you may do it in the neonatal period, but you have to re-evaluate the baby at 3 months for reliable results. Maternal evaluation need not be delayed, and you can check the antibodies or you can do the genetic mutations in the mother immediately. But for the baby, you may have to do the tests a little later and not in the immediate neonatal period. As I mentioned before, it's the placenta which is a focus of interest in stroke. High vascular source of embolization with lesions on the fetal side, and it is called as a fetal thrombotic vasculopathy. So In this, you have chronic myelitis, chorioamnionitis, and fetal vascular necrosis. And whenever they have retrospectively gone back, and when they've seen neonatal stroke, and they've examined the placenta, they have seen is
kindly unmute.
Is very yeah. So placenta is important in neonatal stroke. A word about synovenous thrombosis is a type of ischemic perinatal stroke. You can see most of them occur on day 1 or within the first week. Signs and symptoms vary: non-specific seizures and non-specific clinical signs. Maternal diabetes, preeclampsia, and chorioamnionitis are common. And of course, there's several neonatal risk factors. 90% of them are in the superior sagittal or the transverse sinus, usually associated with a hemorrhagic infarction. And the point to note is 33% of them are associated with IVH. And I'll be discussing the relevance of this when we come down to the management. And of course, for this venous thrombosis, MR venography will be the modality of choice. So let us now see what are the risk factors for this perinatal stroke. In half of the cases, there is no cause is found, but there are risk factors in the mother, in the fetus, as well as in the placenta. You can see thrombophilia, infertility, prolonged premature rupture of membranes, preeclampsia, smoking, drug abuse, infection. These are common risk factors in the mother. Again, thrombophilia in the fetus, congenital heart disease, one of the major causes of perinatal stroke, HIE, hypoglycemia, dehydration, polycythemia and sepsis, and vascular catheters. And the placenta, again, important infection, infarcts, and a small placental size. So these are the known risk factors, fully understanding that in half of the cases, we may not be able to find a proper cause. But what is this thrombophilia? Because it seems to be there on the maternal and the fetal side, and one of the important causes of neonatal stroke. So let us look a little bit into this. It means a hypercoagulable or a prothrombotic state. It may be congenital or acquired. Thrombophilia is present in 50% people with thrombosis. It's a detectable abnormality in the population, but it also needs an additional risk factor for the clinical manifestation. It can be congenital, and you have these genetic mutations that the babies may have. Antithrombin 3 deficiency, protein C, protein S deficiency, and there are other minor ones also. And thrombophilia is also acquired, mainly autoimmune. And this is the antiphospholipid syndrome, anti-cardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. This antiphospholipid syndrome is there in the mother. Antibodies can cross over to the baby. There are several other causes of thrombophilia which are acquired, which are malignancy, nephrotic syndrome, obesity, hematological disorders, and drugs. And you can see pregnancy in that particular group. So you can have a thrombophilic tendency during pregnancy. Why is it important to us? You can see this study in 2009. It shows that 78% of the mother-infant diets with stroke had at least one risk factor for thrombophilia. And the common ones have been shown below: factor V laden mutation, lipoprotein A elevation, protein C deficiency, and antiphospholipid antibodies. These carry the highest risk. So these are important for us to know, because whenever you have a neonatal stroke, we should investigate the mother and the baby for thrombophilia, because most of them are likely to have one of these risk factors. There have been some studies recently which have shown a genetic risk factor for stroke. Surprisingly, prothrombotic and pro-inflammatory polymorphisms are not associated, but some alleles have been identified, like the lipoprotein E. When presence of these actually confers a genetic susceptibility to stroke. So just to summarize, there could be a genetic tendency, there could be some thrombophilia risk factors, and there would be other risk factors like the placenta, or there could be dehydration, polycythemia, heart disease. So you need a genetic risk, and you also need an environmental factor to cause thrombosis. So the clinical presentation can be divided into neonatal and later, and this later is usually in infancy, where you diagnose a perinatal stroke retrospectively. The neonatal presentation is most commonly the form of seizures, usually focal seizures, but the point to note is many babies may be completely normal and may not have any encephalopathy. And we do in our NICU find many babies who have seizures. We do a metabolic workup, we do a CSF, we are unable to find the cause, and then we label them as idiopathic, or we call them a 5th day, 5-day fits and all that. Essentially, you must remember, if you have a baby who's having seizures, completely normal metabolic workup, maybe even normal between seizures, always do an MRI to rule out stroke. However, most other babies will have some signs of encephalopathy like lethargy, poor feeding, apnea, and hypotonia. It is not really known whether symptomatic neonates have a worse outcome than those who are not symptomatic in the neonatal period. Now, this is what I was referring to, and I had a patient who came to me last month, and the only symptom that the mother complained was the child has a hand preference at 18 months, and the child was not using the right limb. He was predominantly using the left limb, and hand preference in the first 2 years of life, within the first 2 years, that particular child had a perinatal stroke. Signs and symptoms can be very subtle, just motor asymmetry in reach, grasp, and hand preference, developmental delay, seizures, hemiparesis, abnormal gait, and they could be manifestations of perinatal stroke that was missed in early infancy. Coming now to the evaluation, we do a hemogram, mainly the hematocrit and a platelet count, a coagulogram, a thrombophilia workup. We do cardiovascular imaging and neuroimaging. If you see this entire list called the thrombophilia workup, and you can see a large number of tests which are routinely done by many of these labs. So it is said that if you have a neonatal stroke, the mother as well as the baby should be investigated for thrombophilia. Now, we already discussed that in the mother, you can do the evaluation soon after birth of the baby, but in the infants, if you have done it early, if you get low values of protein C or protein S, it's always advisable to repeat the workup at 3 to 6 months because report in the newborn may not be reliable. I just happened to talk to my hematology friend. I asked him about all these tests. So most of the labs, hemat labs, are doing all this thrombophilia workup because it's required for many disorders. But he quoted me a cost of around 60,000 rupees to do a full thrombophilia workup. So you can imagine it's a very, very expensive battery of investigation. So as we are discussing again, if you find low levels in the neonatal period, please repeat it again, but do not delay the workup in the mother. The issue is that does it really change the outcome? An expensive battery of tests, you may be able to diagnose a thrombophilia risk factors, not really helpful in the management unless you have some very homozygous or severe thrombophilic disorder. But this thrombophilia workup may help the mother and prevent thrombosis in her and also help her in the next future pregnancies. So thrombophilia workup, if you're a non-affording patient, unable to spend such a large amount of money, remember it does not change the outcome of your stroke, may help the mother later on. So you can defer the workup if required. You did not do it immediately after birth. Neuroimaging is the mainstay of diagnosis. Ultrasound is least sensitive, though the most convenient. And MRI brain is the modality of choice to diagnose perinatal stroke. Diffusion weighted imaging is important to diagnose the edema. MR angiography will be required to diagnose the craniocervical arteriopathy, and MR spectroscopy is sometimes indicated to see the local metabolism. When to do the imaging? If you're doing it within hours of the injury and diffusion weighted imaging very early, then T1 imaging in the first week shows high signal intensity in the gray and white matter. We'll see a few MRIs. And after a few months, there'll be loss of brain tissue and you can see formation of cysts. Most lesions are unilateral. There's a predominance on the left and usually in the MCA artery, 74% are exclusively in the middle cerebral artery. Now we know that CT scan is simpler, it is quicker, you may not need much of sedation. However, not a very great modality for stroke, but you can see this huge hypodense lesion there, which is there on the left side, and that indicates a stroke in the middle cerebral artery. The imaging of choice is an MRI. The image is on the top. This is a 5-day-old newborn, and you can see the T2 images on the top. You can see the hyperintense lesions, which are seen in this area of the middle cerebral artery. There's a loss of the gray and white matter differentiation, and you can see below the diffusion weighted imaging showing extensive edema in that area. So this would be the modality of choice for diagnosis of neonatal stroke. So this is MR angiography, and you can see the block here, and you can see in this extensive edema here in this here. It is a very fresh stroke, and the entire MCA area is involved. And later on, at around 6 months, you can see there is complete loss of brain volume. There is complete asymmetry of the brain and these cystic lesions because of loss of brain tissue. So when you diagnose this presumed perinatal stroke later, you can see the dilatation of the ventricles on the right side, loss of brain tissue, and you can see there is asymmetry of the skull. So this would be the position when you check this perinatal stroke later in infancy. MR venography, the best modality for sinovenous thrombosis. You can see here the sagittal sinus thrombosis in these images, and usually associated with an infarction, and 1/3 of them are associated with a bleed as well. Coming now to the treatment, as we understand, once the stroke has occurred, the treatment is mainly supportive and rehabilitative, control of seizures, and let us talk a little bit about anticoagulation and thrombolytic therapies. There's a different approach of management when you think of arterial ischemic stroke and the sinovenous thrombosis. Let us see how this is slightly different. So in arterial ischemic stroke, there is only supportive treatment, and data does not support antithrombotic treatment once the stroke has occurred. And there are two guidelines. One is the American Heart Association as well as the chest guidelines, which clearly state that there are very small number of babies who would actually require anticoagulation, especially when you do with arterial ischemic stroke. Most of them have a cardiac source, so operated congenital heart disease, or if you are homozygous or have a severe thrombophilic disorder like protein C deficiency. So very, very select number of babies would actually need anticoagulation. But in the registry, 21% of neonatal stroke has actually received anticoagulation. So the guidelines are different, but sometimes our managements could be slightly different. So no antithrombotic therapy in acute ischemic stroke with few exceptions. But for the venous thrombosis, they do recommend anticoagulation. So we give unfractionated heparin, which we don't use that often. Use of low molecular weight heparin, especially if not associated with intracranial hemorrhage. Therapy is usually 6 to 12 weeks, and the thrombus is monitored by imaging for propagation. So arterial ischemic stroke, no anticoagulation therapy. Venous thrombosis, they recommend anticoagulation therapy. But do we have any evidence? We have this 2018 study, in fact, a systematic review that clearly states that anticoagulation therapy, even for venous thrombosis, has no effect on mortality before discharge, whether associated or not with intracranial hemorrhage. However, reduced risk of propagation of the thrombus, but this meta-analysis clearly states that we need many more studies to come to a clear conclusion. So venous thrombosis without hemorrhage, there is no difference in mortality. Venous thrombosis with hemorrhage, again, no difference in the mortality. So even though anticoagulation is being used and recommended for sinovenous thrombosis, current systematic review does not show that it improves mortality in this condition. Seizures have to be controlled because seizures are known to actually increase the ischemic lesion. 2/3 of these babies will require anticonvulsants, And the decision for anticonvulsants again is as we decide for the other conditions. Most of them may not need long-term medication. Treatment mainly early intervention rehabilitation with physical, occupation and speech therapy. But again, efficacy and outcome studies are lacking. As I mentioned earlier in my presentation, very few large studies on neonatal stroke. Based on adult and animal studies, many other emerging therapies, this constraint-induced movement therapy where they restrain the normal limb and make the child use the affected limb, gait training, transcranial magnetic stimulation, hypothermia is one of the mentioned treatments for neonatal stroke, use of erythropoietin and regenerative therapies like stem cell therapy have all been tried in animals and some of them in adults, but still no great studies in the neonatal period. Coming to the outcome, this condition has a very low mortality, just 0.16 per 1 lakh births. Low recurrence risk. So even if you have a congenital heart disease or a prothrombotic disorder, the recurrence risk is very low. But neonatal stroke is known to be a disease with low mortality and high morbidity. And you have a lot of neuromorbidity. Motor deficits, you can see nearly 2/3. Behavior and cognitive disorders, language delay, lower IQ scores in nearly 70%, and epilepsy in these babies. So a disease of low mortality but high neuromorbidity. The commonest deficits are the motor deficits, hemiplegic CP in 37% of those diagnosed in neonatal period. And if it is diagnosed later, it's 82% when you diagnose it later in infancy. So to summarize this presentation on ischemic perinatal stroke, it's slightly under-recognized as a major cause of long-term disability, low mortality but high neuromorbidity, complex pathophysiology which includes maternal, fetal, neonatal as well as placental factors. The presentation usually with neonatal seizures with or without encephalopathy. We also saw this condition PPIS, which is a late presentation of perinatal stroke that will present with focal neurological deficits in later life. Imaging, thrombophilia evaluation and cardiac and vascular Dopplers are the mainstay of evaluation. And we also said that we need to evaluate these mothers and babies for thrombophilia. The mother may be checked early because it may have implications for her treatment and her future reproductive life. But a newborn thrombophilia workup may be delayed for a few months. Treatment of stroke once it occurs is mainly supportive. Anticoagulation has very specific indications both in ischemic stroke as well as venous thrombosis. And the last word on this is still not said. A lot of experimental therapies are being tried. Hypothermia is one of them. And the overall recurrence risk of this condition is quite low. Thank you. Screen open.
Yeah. Yes, sir.
Thank
Hello,
you
Dr. Rekha.
for finishing on time. Go ahead, Prashant.
Hello, sir. Can you hear me?
Yeah, we can hear you. Prashant, go ahead.
Hello.
We can hear you.
Yes, sir. Can you hear me? Can you hear me?
Yes, we can.
Hello, Umesh Vaidya, sir. Can you hear me, sir?
I can hear you well.
Unmute yourself, sir?
Prashant, we can hear you. Go ahead.
Umesh Vaidya, sir, you unmute yourself, sir.
Yeah, I have done
Unmute. Yeah, I think it's coming.
Yeah, you can hear me now?
Is it fine, sir? Am I audible?
Yes.
Yes. Okay, sir. Yeah. We'll move on to the next session, sir. much, sir, for the wonderful session. We will move on to the next session, and meanwhile, I request Kishore Kumar sir to introduce SWARNA REKHA madam.
Hey Prashant, don't throw surprises like this. I am very small to introduce SWARNA REKHA, but I'm sure everybody knows Dr. SWARNA REKHA, but she needs absolutely no introduction. But for those juniors who don't know her, she is one of the very quiet neonatologists who has achieved the pinnacle. She has been professor and head of the Department of Neonatology. She's instrumental in establishing neonatal units in St. John's Medical College Hospital, and she has been known for her social services. She is also instrumental for bringing DM neonatology to Karnataka, and she has been the author, editor of many books, and she has published quite a few articles. Recently, she has become the editor of the Achar textbook of pediatrics, and I think she is involved in multiple projects. And I don't think I know all of her achievements to label here, but I'm sure to say that she is the leading neonatologist of Karnataka and India, and quite achieved. Over to you, SWARNA REKHA. I hope I've done justice for your achievements.
Thanks, Kishore. Thank you so much. Thank you so much for the introduction, and thank you for the good work you people are doing. Kishore, Prashant, and team.
Thank you. Thank you.
Can everybody hear me? Can I start off the presentation?
Yeah, you can.
Slides. Okay, fine. Can I go ahead?
Yes, madam. Yes, madam.
Yeah.
Yes, please.
Actually, the topic which was given was floppy infant, but I have just decided to concentrate more on neonatal hypotonia. It's the same thing, but there are some differences. Let's start off with something very basic, because I presume there are postgraduates and I presume there are consultants, faculty, neonatologists, pediatricians. But for me, it's always important to start off with the basics. So let's see what is tone. This is a very, very common question that is asked to most postgraduates and undergraduates during the exams. So tone is, and most people do get stuck with this. So tone is the resistance of muscle to passive stretch. And you have the postural tone, which is what we normally test, which is a sustained low intensity muscle contraction. And this is assessed by manipulating the limbs, passive manipulation. Now, whenever we're evaluating a neonate with hypotonia, we need to distinguish these two things: hypotonia, which is diminished resistance to passive stretch, and weakness, which is diminished muscle power or strength. In most cases of central hypotonia, weakness need not be present, and weakness is definitely prominent in those with peripheral hypotonia. Prashant, do I change, or will you change the slides? How does it work?
You can change, ma'am. You can change, ma'am.
All right. I'm not able to change it.
If you're not able to do, I'll do it for you.
Yeah,
no
just
problem.
change for please. Changed?
Yeah.
It's not showing up here.
It will take around 5 to 6 seconds delay will be there, ma'am, once I change from here. Yeah. Is it fine now, ma'am?
No. Anyway, I'll continue. That doesn't matter. I don't know whether everybody is seeing the change slide or not, because I'm not seeing the change slide. Yeah. Okay, fine. Now it's come. So I must say that the first time I read up about floppy infant was from this beautiful monogram written by Victor Dubitz. And I still used to recommend it for all my postgraduates in St. John's. The small little red book, which has got everything you want to know about a clinical approach to a floppy infant. And I think one of the most important statements that he has made is, it's important for the clinician to remember that making a diagnosis of a floppy infant is only the beginning and it is not the end, because once you've made a diagnosis of a hypotonic neonate or a floppy infant, then we need to start looking at the etiology. The second important statement is that hypotonia is not a diagnosis, but it is a symptom, just like fever. And it occurs due to multiple disorders affecting the neuron, muscle, and its connections. Prashant, could you change the slide, please?
Yes, ma'am. Yes, ma'am. It's happening.
Has it changed for you people? Because then I'll just go on speaking.
Yeah.
Right.
It's changed now.
So since I have said that I'm concentrating on the neonate and not on the infant, I just thought, let me bring about, does it really differ, or are we talking about the same thing? Now, if you look at neonatal hypotonia, the central causes are much, much more common than the peripheral causes. Whereas in an infant, an older infant particularly, more of myopathies and SMAs is what you're going to be seeing. The clinical presentation in neonates, in addition to hypotonia, will be feeding difficulties in respiratory problems, whereas in an older child, it is more likely to present as a floppy baby or delayed motor milestones. Examination, of course, all of us will agree that it is going to be difficult to assess in a neonate. It is a little less difficult in an older child. And progression, a lot of the central causes of hypotonia, the hypotonia may not persist during infancy, and in fact, they can get hypertonic. Whereas when you're looking at an infant, the hypotonia is obviously going to persist because these are mostly the peripheral causes. So the overview of this presentation is going to be something like this, that I'll be talking about the clinical presentation in the neonatal period. How do you assess a neonate with hypotonia? What are the causes of hypotonia in the neonatal period? The clinical and diagnostic approach, principles of management, and recent advances in diagnosis and treatment with specific examples depending on how much time we have. So let's go on to the next slide. The clinical presentation is not just about a floppy baby. It is not just about hypotonia. It's much more than hypotonia. So let's look at this baby. This is a term neonate born to an apparently uneventful pregnancy by cesarean.
Ma'am, unmute, ma'am. Unmute yourself, ma'am. Ma'am, unmute yourself, ma'am.
Okay. So this is a
Yes,
term neonate born apparently uneventful pregnancy, had respiratory difficulty, low Apgar, resuscitated, and required invasive ventilation. Initial chest X-ray normal, required minimal settings, but a few days later noticed to have hypotonia more than what one would expect. Can I go back to the previous slide, please? Can I go back to the previous slide?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah.
It's happening.
So the hypotonia was little more and had problems weaning the baby off the ventilator because of poor respiratory effort. And then finally, it was decided that maybe this is a neuromuscular disorder and was investigated and later turned out to be an SMA1, spinomuscular atrophy type 1. Now, the importance of this case scenario is the counseling to the parents. When you have ventilated this baby, initial chest X-ray normal, required minimal settings, we're going to be giving a very good prognosis to these parents. Don't worry, the baby is going to be all right. But when we then realize that this baby is hypotonic, the whole prognostication differs, and this is where we need to be a little wary about how do we handle these kind of scenarios. Can I have the next slide, please?
Yeah, it's happening.
Yeah, okay, fine, I will wait. So there's going to be a little interrupted presentation. Okay, so what does the clinical presentation look like? The clinical presentation will be, I think, again, we all talk in neonates, antenatal history is very, very important. So decreased fetal movements, something very, 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 very important to elicit Most mothers may not be able to appreciate it, especially if they're primigravida, but subsequently the second pregnancy, they may be able to make out. And polyhydramnios is something which we need to look at whenever there is a neuromuscular disease. Postnatally, it could present as an asphyxiated neonate without any obstetric problems. Need for ventilatory support immediately after birth, like what we discussed in the previous scenario. It may have dysmorphic features, hypotonia, paucity of movements. A lot of mothers and nurses are going to tell you, are able to tell us, no, this baby is not moving too much. A weak cry. Now, just to reiterate that this paucity of movements and weak cry can sometimes be interpreted as lethargy, but we must check whether this baby is alert and has paucity of movements, or is it a depressed baby and has paucity of movements. Now, further in the postnatal period, the baby can have poor respiratory effort, requiring ventilation, may have to have difficulty, previous slide please, may have difficulty in weaning the baby off the ventilator. And can I have the previous slide please?
Yes, madam. Yes.
Yeah. There could be excessive secretions. The baby may present with an aspiration pneumonia. There could be feeding difficulties, inability to latch on, inability to swallow, and there could be arthrogryposis. The reason for arthrogryposis in a severely hypotonic neonate is something very, very simple and mechanical. If the fetus is not having any movements, there will be joint contractions, and this is why a lot of these severe hypotonic babies present as an arthrogryposis. Again, when we're looking at clinical presentation, I'm sure all of you will associate these pictures with a hypotonic neonate. A Down syndrome, it could even be normal. It could have a myopathic face, hypotonic, or when you do a ventral suspension, the baby looks like a rag doll. But what is more important as in the NICU and as people dealing with sick neonates, next slide, would be that these babies could have feeding difficulty. They may have to be on tube feeds. The severe ones may need a gastrostomy. A lot of them require ventilatory support, and sometimes they may go home on a tracheostomy. So I hope you get the clinical picture of a neonate with hypotonia. So let's go into the history taking. Family history, consanguinity, early neonatal deaths, age of parents, maternal illness, drugs, teratogens, infections, polyhydramnias, abnormal presentation, and decreased fetal movements. Again, because of paucity of fetal movements, a lot of these babies present as breech presentation, and that's one of the things that you will think of for a neuromuscular disease. Continuing with the history, you're going to ask for need for resuscitation, the Apgar scores, because the Apgar score may be low just because the tone is going to be less, or because the baby has a poor respiratory effort. What is the level of alertness? Have there been any seizures, especially if you have a 10-day, 15-day baby presenting with hypotonia? You're going to ask these questions. What is the quality of cry? Are there any feeding difficulties? Are there a lot of secretions? How is the respiratory effort? Are there any breathing difficulty? And what is the spontaneous activity? Dr. Umesh just talked about spontaneous activity, how you can pick up asymmetric spontaneous activity tells us there is a stroke. So here again, decrease in spontaneous activity may give us a clue to a neuromuscular disorder. Now, when you're looking at the clinical assessment, we are finished with the history taking. Clinical assessment, we need to keep in mind gestation. All of us know that the lower the gestation, the lower the tone, and therefore the tone has to be assessed based on the gestation. And most neurological assessments are for a term or a near-term neonate for assessing the tone. Posture is going to be frog-like, limb movements, ventral suspension, the anti-gravity muscles, they're not going to be. That means basically there is going to be decreased spontaneous movements when the baby is supine. And in ventral suspension, you will see like the baby is hanging down. There's going to be decreased resistance to passive movement, hypermobile joints, poor muscle strength, or sometimes in central hypotonia, muscle strength may be normal. Hip dislocation is something you need to look for. Umbilical hernia, and of course, deep tendon reflexes, which gives us a clue as to where is the localization. So if you look at it, the posture the movements, the resistant to passive movement, hypermobile joints, hip dislocation, all of these give a clue to hypotonia. How do you assess these babies? Of course, one is the simple, what is referred to commonly as the 180-degree test, that you pull the baby to sitting position. There is a head lag, a rounded back, and axillary hang. You will find that the baby is slipping through. And when you hold the baby in ventral suspension, the head and the limbs are flail. Any person looking at neonates or the first year of life, we must know about Emil-Thiessen angles when you're looking at either hypotonia or hypertonia. And, the procedures which are done, I'm sure a lot of you will be knowing. Scarf sign.
Ma'am, unmute, ma'am. Unmute, ma'am. Unmute.
Okay, fine. So I hope everybody heard about the Emil-Thiessen angles. Can we have the next slide, please? Next slide, Prashant. Now, for postgraduates, I've often taught how that we need to do Emil-Thiessen angles, and I have often shown the video of this to the students, particularly the DNB students, because this is asked as one of the OSCE stations. The only message from this slide is, yes, we can look at angles visually, but using a goniometer may be more ideal to get the exact angles. So here the popliteal angle, the adductor angle, and the scarf sign is shown in these pictures. And whenever we are assessing this, the head has to be kept in the center because the tone may vary otherwise. I'm going to spend a couple of minutes on these Emil-Thiessen neurological assessment term. I thought this is a very impressive way of assessing neonates, particularly those with neuromuscular disorders, because this combines both the entire neurological examination and including the tone. And there are some very interesting points which I would like to bring out, and maybe we need to start training ourselves in utilizing this in addition to the conventional angles that were first talked about in the 1960s. So the AT-NAT, as it is called, which was developed in 2002 over a long period of time, it's basically for the term neonates within the first few days of life. Preterm neonates, you can assess them at corrected age of 37 to 40 weeks. And each of the parameter has got a scoring of 0, 1, 2, and X if it cannot be defined very clearly. The usual neurological examination in history, taking of birth details, etc. Next slide. Head circumference, suture, anterior fontanelle. Next slide. What is the motor activity during the examination is something that you're going to be observing. Can I have the next slide, Prashant? Does the baby fix? Are there any ocular signs? This is something very interesting, I thought. We never really look at response to voice and social interaction in a neonate. But we often do this. We often say, we whistle or we look at the baby or we call the baby's name. And I think they do respond. So these are the two things which have been incorporated in this neurological examination. Crying, excitability, convulsions, spontaneous motor activity, thumb adduction, which tells you there is a central cause. Next slide. Passive muscle tone, active muscle tone, which is usually done by writing reflexes, primitive reflexes. And again, something very nice. How does the baby adapt to manipulations during examination? This is something I have often talked when we're doing a newborn neurological examination. You need to look at the states of the baby. But here, in addition, we look at how does the baby adapt. Feeding autonomy. How often do we test this when we're doing a neurological examination? This is something very nice. The medical status at the time of examination. Were there any unfavorable circumstances at time of examination? For example, the baby was sedated or the baby was a preterm, etc. And then you synthesize the data to arrive at a diagnosis. And you say that there are no neurological signs, or there are mild or moderate or severe. And if you do this examination over once or twice, you can actually decide whether it is static or dynamic. And you could come out with a probably neurological impairment. Next slide, Prashant. I was really impressed with this 18-act assessment. So far we have talked about how do neonates present, what is the history and clinical examination, and how do we assess these neonates. We now go on to the causes, and as undergraduate.
Ma'am, unmute, ma'am. Ma'am, unmute.
I'm unmuting. I'm checking it periodically, Prashant. Thank you. So right up to the spinal cord, anterior horn cells, nerve, and muscle, neuromuscular junction. So the etiology is in all these places. Next slide. Next slide, please. So if you had looked at an older textbook on a floppy neonate or a floppy infant, possibly this is all that it would show. Central causes, peripheral causes. Central would be asphyxia, acute conditions, metabolic, genetic. Peripheral would be spinal cord, SMA, neuromuscular, peripheral nerves, muscle. But now with evolving availability of genetic and molecular tests, I think we have got a lot more diagnosis, which is presenting in the neonatal period as neonatal hypotonia. Now, this is only to tell you that studies have shown we really don't have too much of data in the neonatal period in India. Can I have the next slide, please? We really don't have too much data of neonatal hypotonia in India, but this is data from outside, and it shows that predominantly central hypotonia, if you look at it, 51%, 70%, 66%. So predominant causes in the neonatal period is central hypotonia, and peripheral hypotonia accounts for a much lesser number of cases. Next slide. Next slide, please. So let's start looking at the causes. If we look at the central causes, the first thing possibly you need to rule out is acute illness, because acute illness can present as lethargy and hypotonia. And of course, the non-progressive encephalopathy, which we're all very familiar with, hypoxic ischemic encephalopathy, malformations, migration disorders, genetic causes, chromosomal disorders, mutations, mitochondrial disorders, inborn errors of metabolism, the classical inborn errors, peroxisomal disorders, storage disorders, hypothyroidism, I think is something very common as a presentation in the neonatal period. But I hope we don't see too much of it because of the newborn screening. So what are the syndromes which cause hypotonia? We have the Down syndrome, Prader-Willi, a whole list of them are there. And what are the metabolic diseases? Again, a whole list of there which present in the neonatal period as neonatal hypotonia and its associated symptoms. Next slide. Next slide, Prashant. So we have syndromes, we have metabolic causes, and we have acute illness. Can I have the next slides, please?
Yes, ma'am. Yes, ma'am. Yes.
Yeah. So we have metabolic causes. I'm not going to go into these details. This is, if somebody downloads these slides, it'll be a good list for postgraduates to write up their answers. Next slide. And we have acute illnesses which can cause this. So we've talked about the central causes. Now let's go on to the peripheral causes. And if you look at the peripheral causes, spinal cord injury, very rare. And I had seen one neonate who had severe birth asphyxia. This is long ago. And the baby had a cervical cord injury and actually had flaccid paralysis of the paraparesis, upper and lower limb. But it's very rare, and we certainly don't want to see that. Then, of course, the spinal muscular atrophy, anterior horn cell disease, hereditary neuropathy. Just one word about the hereditary neuropathy. A lot of them may be motor, but some of them are sensory motor, and therefore later on they may present with injury because of insensitivity, along with developmental delay. And we have seen a couple of these hereditary sensory neuropathies. Then, of course, neuromuscular junction disorders, that is myasthenia and botulism. The importance of diagnosing both these are because botulism you can treat with the immunoglobulin, and myasthenia again is some extent a treatable condition, and therefore we need to make this diagnosis. And in muscle disorders, you have the myopathies, the muscular dystrophies, the congenital myotonic dystrophies, and the metabolic myopathies. Again, I'm not going to go into this list. The huge number of myopathies and muscular dystrophies which can present in the neonatal period. These are some of the commoner ones, but all this can only be diagnosed after muscle biopsy, though some of them have some clinical features to say that maybe, yes, this is a myopathy or a Nemelin rod myopathy or whatever. So after having dealt with a reasonably extensive list of causes, let's go on to the clinical approach if a neonate presents with hypotonia and its associated symptomatology that we have discussed. The first question, this is basically for the postgraduates if anybody is listening. A lot of times we have a sleeping baby and we say, okay, this baby is hypotonic, or a baby who's been sedated, or a mother who's been sedated and you find the baby is hypotonic. So I think this is something very important for us to distinguish. All we need to do is touch the baby responds, then we know that this is not a hypotonic baby, this is just a sleeping baby. Is it due to an acute illness? It's quite often that when you're examining neonates in the NICU, you will suddenly find this baby is tone is a little less. And the first thing which comes across, especially with UMESH VAIDYA listening in, is nutritional. Is this baby malnourished? But I think there are a lot of other acute illnesses which will cause hypotonia, which I had mentioned earlier, and we will deal with it again. The next question we need to ask is it central or is it peripheral? And if it is central, is it genetic syndromic, non-syndromic, or is it metabolic? So are there any clues to say, is it genetic or metabolic disorder? Next slide, please. So how do we distinguish? Okay, before we go on to distinguishing central from peripheral, let's look at this case scenario, which I'm sure each one of you have seen. Late preterm, born to PIH mother, poor respiratory effort at birth, required invasive ventilation. Of course, nowadays you may not put it on invasive ventilation, may be able to manage with CPAP. Documented to have hypermagnesemia, corrected, the baby was extubated and discharged. So this is something beautiful. This is what we would like to see, not those SMAs. So it's something very important that if you find that the tone of a neonate, especially a sick neonate, is a little less, more less than what you normally see in these conditions, please look at electrolyte imbalances, calcium, magnesium, phosphorus, sodium, acidosis, sepsis. Just a word about vitamin D and B12. I have not seen this in the neonatal period presenting as hypotonia, but in early infancy, sometimes when you follow them up, you'll find that the tone is a little less. And if you look at D, you will find that hypovitaminosis D can cause hypotonia. And there's a recent report about B12 deficiency presenting in the first 3 months of life, neonatal B12 deficiency, nutritional deficiency. And they found that the mother's B12 was very low and the neonate's B12 was very low. It's something, these are treatable conditions and something we need to keep in mind. So we go back to the approach. So we have said we need to rule out any acute illness, and then we need to figure out, is it central or peripheral? Obviously in central, the sensorium is going to be abnormal. There could be history of seizures, movements are reduced, tendon reflexes are brisk or normal in CNS causes and reduced or absent in the peripheral causes. Hypotonia is more axial in the central and more generalized in the peripheral. Dysmorphic features could be present in the central causes, myopathic phases in the peripheral causes, fisting or cortical thumb will be present in central, and weakness will be less in the central causes, and weakness is more severe in the peripheral causes. So we can figure out, next slide, central or peripheral. And are there any clues to say that these are, any specific diagnosis? Large tongue, of course, you will definitely, a protruding tongue, you will think of Down syndrome or any hypotonic baby, but a large tongue, you will think of storage disorders, organomegaly, storage disorders, abnormal odor, cataracts, undescended testis, Prader-Willi syndrome, and dysmorphic feces and Downs, so any number of syndromes. So now that we have looked at how do you distinguish central and peripheral, let's look at in peripheral. If it is peripheral, how can we localize it? Is it myopathy or muscular dystrophy? Are there any clues to specific diagnosis? And is there any feeding and respiratory difficulty? Next slide, please. So for localization, I think again, clinical examination. Again, clinical examination. Obviously, in the peripheral causes, sensorium is going to be normal. There are going to be no seizures. But muscle involvement, in neuromuscular, bulbar involvement is common, and you will get a progressive worsening of the muscle weakness. In anterior horn cell and muscle, the proximal weakness is higher, and in nerve, distal weakness is more. Fasciculations is likely to be present in anterior horn cell disease and fibrillations in the nerve-related disorders, and of course, dysmorphic features in the central causes. Typically, SMA is an alert baby, unless, of course, the baby has had an hypoxic insult, and you may have a myopathic face or ocular findings in myasthenia and in the myopathies. The next is, how do you decide, is this myopathy or muscular dystrophy? In neonates, this is going to be very difficult because none of these you're going to see. So we may have to rely on a creatine kinase, which is normal in the myopathies and which is increased in the muscular dystrophies. Next slide, please. So we've talked about how do you further localize if it's a peripheral, and let's see, are there any clues to say that, next slide, what are the causes of these peripheral neuromuscular disorders? Tongue fasciculations, which you may or may not see in neonates, is anterior horn cell disease, ptosis, external ophthalmoplegia and the myasthenic syndromes, arthrogryposis we have talked about. Congenital myopathies typically have a high arch palate, and myotonic dystrophy, inability to open the hand after a strong grip. I've not seen this in a neonate, but I've seen this in an older child, and it's a very, very typical feature. All right. So we have looked at the causes. We have looked at how do we kind of arrive at whether this is an acute illness, whether this is central hypotonia, and whether this is peripheral hypotonia. Next slide. So now we go on to how do we investigate these babies. Again, I'd like to spend a little time on this. I'm not going to go into the details of the investigations, but just the philosophy. A lot of times we hesitate to do too much of investigations for practical reasons, that maybe some of the tests are not available, expensive, it is invasive, anyway there is no treatment, parents don't want to do it because the prognosis is poor. But I think we must understand that it is important for us to arrive at a specific diagnosis, for prognosticating, for counseling about the next pregnancy, and a lot of these neuromuscular conditions and metabolic syndromes have specific therapies available, and therefore we must try and investigate these babies. Next slide. Having said that, if we really do a thorough assessment of these hypotonic neonates or even the floppy infants, clinically we should be able to come to a diagnosis. But we do need certain tests to make sure that we have the more specific diagnosis. And I particularly put this particular slide for a reason. I was very impressed with this article of the role of the clinician in the multi-omics era. You have a whole lot of omics now, the genomics, proteomics, etc., etc. And we have a whole lot of results which are coming out. But what is important is for us to know how to analyze and gather this information and interpret it correctly. So we need to educate ourselves, and it's not just simple to say, fine, refer to a specialist, but I think we need to know a little more of these newer omics so that we can interpret and counsel. Very interesting study. In fact, there is a similar study done earlier on, but this is from Sri Lanka 2013. And when they looked at a group of neuromuscular neonates presenting with neuromuscular, they were able to pick up a clinical, in 50% of the cases, they were able to pick up a clinically the diagnosis. With neuroimaging, another 13%, with clinical genetic evaluation, 9%, and with genetic and metabolic workup and further evaluation, another 20%. and with a neuromuscular workup, another 6%. So the message here is very, very clear. The reason why I have spent so much time on the clinical approach is that a lot of times you will be able to focus down to a certain possibility or a certain group of possibilities. And this is going to be very useful, particularly in planning the genetic screening and genetic tests, because if you know what it is likely to be, we are more likely to get a better yield from the genetic. Yeah. So if we have central hypotonia, we need to make sure that our electrolytes, calcium, sepsis, etc. are all right. Neuro
Ma'am, unmute. Ma'am, unmute, ma'am, unmute, ma'am.
whole array of tests are there. And of course, the inborn errors of metabolism workup, not just the 5-panel, 6-panel, but the entire thing which you're. Again, rather than just doing the entire panel, if we have a clinical diagnosis or a clinical set of possibilities, it becomes easy for the diagnostic laboratory and for us to arrive at a diagnosis. So I still, as usual, emphasize the importance of clinical medicine. Next slide. So if you're looking at peripheral neuropathy, peripheral causes of hypotonia, there's a couple of interesting points which I need to bring out. Of course, creatine kinase, not creatine kinase. The EMG, nerve conduction, muscle biopsy, molecular genetic testing, muscle imaging is something which seems to have come up in a big way. One is to look at the extent of involvement and progression. Second thing is to decide on the site of biopsy, because you want an involved muscle to where you're going to do a biopsy. There's no point doing it on a normal muscle. And this is one of the difficulties we have. Though classically we say in a newborn, the muscle biopsy is taken from the anterior lateral part of the thigh. But, it's useful to have a imaging to say, all right, is this affected muscle, not affected muscle, and let's do a biopsy. Again, while talking about EMG and muscle biopsy and nerve biopsy or nerve conduction, it's not an easy investigation to do in neonates. One, it's invasive. Second is, as it is, this baby might have been on a ventilator for some time. You just weaned the baby off ventilator. You decided you want to do a muscle biopsy. The pediatric surgeon will come and say, no, I need to give general anesthesia for this baby. And you're worried this baby is going to have an aspiration or a respiratory problem, so you have the ventilator standby. So it's quite complicated, but this is theoretically we need to do all these tests. The other thing is about DEXA is being used again in older children to assess the muscle mass, not so much in neonates. This is given in any textbook, so I don't think I really need to talk about it, except that I think we need to educate ourselves about this. We need to understand how an EMG is done. We need to sedate these babies for the EMG. And when you sedate again, it's got its own problems, especially if this baby is hypotonic. And we need to look at the spontaneous, the resting muscle, what it does, and what is the contraction muscle, what it does. Okay. So we come back to this approach slide. We have decided whether by clinical acute illness, and we have looked at the acute causes, and most of these are treatable, fortunately. Then we looked at central hypotonia and do these studies to arrive at a diagnosis. And we have clinically come to say that this is a peripheral hypotonia and do these investigations to come out with a possible diagnosis. Next slide. So we finished talking about the presentation, the causes, the approach, both the clinical and the diagnostic approach. So let's look at the principles of management. If you're looking at a floppy infant, and especially if you are an examiner or a postgraduate student, most often you will say occupational therapy, physiotherapy. But in the neonatal period, of course, even in early infancy, this is important, but respiratory management, we have already discussed this. There are going to be a lot of secretions. The baby is likely to have aspirations, and we may need to continuously suction out the baby's oral cavity. We may have to provide some kind of invasive or non-invasive support. A lot of these babies may go home on CPAP. A lot of them may go home on tracheostomy. So this is a very important aspect of a hypotonic neonate. The second, again, is feeding. In fact, this could be a clue. You know, the baby has had regurgitation, the baby has had a lot of secretions, baby is not latching, baby is not sucking. It's a very common presentation of a hypotonic neonate, whatever the etiology. Can we just go back to the previous slide, please? Whatever the etiology, and again here, suctioning. How do we breastfeed these babies? Do we need to give it Pallada feeds? Do we need to keep it on tube feeds? And sometimes in the real severe cases, we've had a couple of cases like this, where we've actually had to send these babies home on either a continuous tube feed or on gastrostomy. So these are very, very difficult to manage. And with all the problems these neonates have, you certainly don't want nutrition to be another problem, and therefore we need to concentrate on this. Of course, physiotherapy and occupational therapy is very important. Orthopedic considerations so that they don't go into contractions, or if they have arthrogryposis, can we do any corrective surgery? Psychosocial support, I think, is something very important. Psychological support to the family is very important. That is obvious, but also social support. Simple things. A lot of times we call these babies to the follow-up clinic, some dysmorphic baby or a hypotonic baby or a syndromic baby. And I've had parents tell me, look, it's very difficult for me to get this baby to the hospital because everybody stares at the baby. And fortunately, in the COVID time, there seems to be an answer to this with telemedicine. But please look at the psychosocial problems and not just the psychological problems. Counseling, again, very, very important. I have brought out this issue in the first case scenario. Many times we land ourselves in problems saying, no, the baby is doing well, don't worry. We should be able to send it home soon. But then we realize that this baby has got a neonatal hypotonia, a metabolic disease, a genetic syndrome, and it causes a lot of heartbreak to the parents and a lot of heartburn to us who are counseling. So counseling would be, what is the diagnosis or what is a likely diagnosis? Sometimes we don't have a diagnosis, especially when it is a non-syndromic, just a set of malformations. We say we don't have a diagnosis. And nowadays, a lot of the parents will look at the net and say, no, doctor, this may be the diagnosis. So we need to counsel about that, the prognosis, the recurrent risk, the course and its complications, treatment plan, if any, and family support. So that brings us to a general outlook of how you deal with a baby with a neonate with hypotonia. The last part of the description, of the presentation was about recent advances. And I just want to make this point basically to say that in 2020, COVID or no COVID, we need to be prepared to make more accurate diagnosis and more accurate treatment. What is called the piece, the personalized, the precision, preventive medicine. And I think this is something very important. So let's look at SMA as a prototype. There's a hereditary, and again, another reason why I have put this is one of the most common neuromuscular conditions and one of the most common things which are asked to a postgraduate. So this is a hereditary neurodegenerative disease, autosomal recessive. Defect is in Q13 region of chromosome 5. And the problem is with the SMN1, the survival motor neuron 1 gene, and the SMN2 gene. This is something important that we need to understand the pathophysiology, that the SMN1 gene produces SMN protein, and if there is a deletion in the SMN1 gene, there is a deficiency of this protein, and therefore it leads to the clinical manifestations. SMN2 gene produces a small amount of SMN protein, and therefore one of the therapeutic modalities which is used is to stimulate the SMN2 gene to produce more SMN protein. So why do we need to go into such depth of diagnosis? Because it has got therapeutic implications and a lot of research information that we can get. And I was a little surprised because my impression also was that a lot of more likely to be presenting in the later part of infancy or in early infancy. But this is a study, again, I think from Sri Lanka, which says that nearly 35% of neonates present in the 35% of SMA is present in the neonatal period, and another 15-16% present in the first month. So we are going to be seeing almost 60% of SMAs presenting in the neonatal period. We have discussed about these presentations, but I just want to make a point that when we're approaching a baby, we need to look at not only what the baby has and what the baby doesn't have. Like in an SMA, facial movements are preserved, extraocular muscles are normal, and there is no sensory or sphincter involvement. So if you do find a sensory involvement, you're going to be thinking of a nerve-related disease. So not only what the baby has, but also what the baby doesn't have to arrive at a clinical diagnosis. Next slide, please. So how do we investigate this baby with SMA? CPK will be normal. EMG will show fibrillation potentials. Nerve conduction will be normal. Muscle biopsy may not be necessary because it is only going to show muscle atrophy unless you're not sure of the diagnosis and therefore you do a muscle biopsy and molecular diagnostic test to identify the actual deletion. Next slide. And which is available now not only for the deletion but also for a carrier state. Treatment, we have discussed this, but just to emphasize, a lot of it is going to be supportive therapy, feeding and respiratory, targeted improvement of muscle strength and function, but there are newer modalities. SMN1 gene replacement is still in phase 1, phase 2 trials. I don't think it's come into phase 3 at all. But modulating the SMN2 gene so that it produces the full-length effective proteins. This is a medication which has been approved by FDA in 2016. Again, for postgraduates, this is one more medicine which is given intrathecally. I'm not going to go into the details about how you do. I don't even know whether it's available in India. But in this world of where the globe is so small, you can certainly get this in case we need it. So it's extremely important. It's just not SMA. It could be SMA. It could be a myopathy. It could be a lysosomal storage disorder. It could be GST. We have to arrive at a diagnosis, provided parents agree, facilities are there, money is there, etc., etc. And then we need to try and give the treatment for these babies. So just to summarize, it's a common clinical manifestation of acute illness in neonates. So let's not get fooled by, oh, this baby is sick, therefore hypotonic. Let's keep neonatal hypotonia in mind, correct the acute abnormalities, and if it persists, make a diagnosis of neonatal hypotonic syndrome. Recognizing treatable conditions is very important. Central causes of hypotonia are more common. Clinical and basic diagnostic workup, we can get up to 60 to 70% of diagnosis in neonates and in children. Advanced genetic and metabolic workup should be done to make specific diagnosis, to look at the mutations for counseling, etc., to plan therapy and to prognosticate. And supportive therapy, which I have emphasized enough during this presentation, is very, very important in addition to occupational therapy and specific therapy whenever available. So the gist is, let's not miss out on neonatal hypotonia. We need to have a high index of suspicion, especially when you're looking at a baby in the NICU. So possibly I would say the red flag signs are a baby with feeding difficulty, a baby with dysmorphic features, a baby whom you have problems getting the baby off ventilator. These would be the red flag when you will think twice and say, am I dealing with a sick baby, or does this baby have a hypotonic syndrome? Thank you so much for your patient hearing. I hope I have been able to concisely present this difficult topic. Thank you very much for the opportunity.
So there's really thank you for making such a complicated subject so concise and beautiful, SWARNA REKHA. But there's only one other person who could have done such a brilliant lecture. That is Dr. Dubovitz himself.
Oh my God! No.
No, honestly, I've heard him talking once, and I'm telling you, yours is better than his. Thank you very much. I'm tempted to tell you this, SWARNA REKHA, that
Yes.
we at Cloud9 Jayanagar, we are starting a newborn screening for SMA type 1 on a pilot project with the
Excellent.
European Union from next month. And if anybody is interested to join us, this is a pilot project. It's not going to cost anything. We will be doing newborn screening for SMA.
I think people should take this opportunity and get the babies who have, they suspect they should do it. I'm happy you started off this, and I'm sure you will make things available to everybody else also, all the other tests that we were talking. Thanks,
No, in
Kishore.
fact, we want for every baby, not just a suspected baby, because
You're doing
really want
you're doing a screening. I get it, because there's again a lot of reports about SMA screening and what are the implications for, how do you handle these babies if the screen is positive. So I think that people should take this opportunity. Thank you for informing.
Thank you.
Yeah,
And
yeah.
Umesh, sorry I didn't get a chance to tell you at the end of your lecture. That was brilliant, and answer to the point, and you were well on time, and you covered everything starting from basics to most modern technology. Now we open the podium to questions.
Yes, sir. Thank you very much.
Madam, thank you, madam. Madam,
Yeah.
I'm Dr. Kotresh.
Yeah. Yes, sir.
Thank you, madam. Apart from the things you have given presentation on hypotonia, the care area presently needs your blessings to go well under your guidance.
Sorry, sir, I didn't hear. Oh, yes.
Apart
No,
from
don't worry.
this
Don't worry.
series,
Everything will be fine, because you people are doing a great job. So do not worry about it. Just continue to do your good work. That's all.
nice of you, madam. Thank you, madam.
Yes. Sure.
Yeah, sir, Maya sir, I have WhatsApped you the question which has come to me. You can just open up, Maya sir. Maya sir, are you there? You can unmute yourself, sir. Maya sir.
Yeah.
Yes, sir. I have WhatsApped you the question, sir.
Yeah.
Yeah, you can start asking.
Prashant, can I have a minute? Can I say something?
Yes, ma'am.
I just got a message
sure.
from Dr. Asha Bekama. She says it's available, the medication that I was talking about, which also goes by the trade name of Spinraza. Not the trade, the pharmacological name of Spinraza is available free of cost. And she has given some details, I'm sure. So anybody who has a baby who has been diagnosed as SMA, please contact Dr. Asha, because this therapy is available. And I think, again, to reiterate what Kishore said, it's important for us to start screening for this, because there is something that we can treat this with. Sorry for the interruption. Go ahead.
Yeah. Yes, sir. Maya sir, you can go ahead, sir.
Where are the questions?
Yeah, WhatsApp. I WhatsApped you, sir.
Oh, I have to take.
Say it, sir.
Yeah, I don't have the questions.
Sir, I WhatsApped you, but yes, sir.
I don't see that here.
Okay, sir. Just WhatsApp it. Exact definition. This is for Umesh sir, Vaidya sir. Exact definition of perinatal stroke timeline is: does it start from 20 to 22 weeks and 28 weeks, ends at 7 days or 28 days?
Yeah, the definition says 20 weeks to 28 days. So it's a pretty broad range.
Yes, sir. Yes, sir.
Yeah, so it's a pretty broad range, right from 20 weeks to 28 days of life, but most of them would occur in the first few days in the neonatal period.
Mahesh sir, did you receive now?
Yeah.
Yes.
Yeah, first question is exact definition of perinatal stroke timeline is, does it start from 20 to 22 weeks and 22 and 28 weeks and ends at 7 days or 28 days?
Yeah, so I just answered that. It is 20 weeks to 28 days. It's a pretty broad definition.
Okay. Next question is why left hemisphere is more affected?
That is usually because of the PDA, and most of these emboli, they go from the placenta into the right atrium, move to the left atrium to the patent foramen ovale, and then go through, because of the duct, they go directly to the left side of the heart. So that is the reason why most of these occur on the left side of the hemisphere, left hemisphere.
I think it's nice. And next question is, what is the indication for low molecular weight heparin?
Yeah, as I mentioned in the presentation, that most of these strokes, which are arterial ischemic strokes, where you don't have a clear large thrombus, there it is not indicated. But most people use it whenever you have a large thrombus in the sagittal sinus or the transverse sinus, so the venous thrombosis. But if you have a clear source, like a cardiac source, a large thrombus, or you have a severe thrombophilic disorder, then anticoagulation with low molecular weight heparin is used. That would be much safer in the newborn. But the last word is still not said on this. There is still highly controversial. We don't have much studies, and use of anticoagulation has not shown major change in mortality.
Next question is, this particular question is same as before. It is being questioned as unfractioned heparin in perinatal stroke. What is the difference?
Yeah, I
Whether
think
in AIS we should use UFH.
The safer one is low molecular weight heparin, but unfractionated heparin is sort of cheaper as compared to low molecular weight heparin. But honestly, most of the current recommendations are in favor of low molecular weight heparin only and not unfractionated heparin.
Next question is, can you use heparin, this aspirin in neonates? If yes, tablet form or any other form?
Yeah, the most of these drugs that are used in older children, adults, like aspirin, or sometimes they use all these thrombolytic therapies, they are not indicated in neonatal stroke. Even statins, even some people have tried statins also in neonatal period, but very anecdotal. And though most of these therapies are not recommended for neonatal stroke.
What is real cause of AIS, since we know CSVT is mainly dehydration or infection?
Yeah. So as we looked at the etiology and risk factors, we know that a large number of them are idiopathic, but we should call them idiopathic only when we have done a thorough investigation into all the causes. So for example, they say that you must do a placental examination, provided a placenta is available to you. Also, you must investigate for thrombophilia, because that is one of the commonest causes why babies get that. Congenital heart disease, or your vascular catheters causing thrombus, all those things would be very obvious from the clinical setting. But I personally feel an attempt must be made to find the cause of the stroke, fully understanding that in 50% of them you may not be able to find a reason.
Thank you, Umesh. I think whether I am conducting YOOC for you, there are so many questions.
Yeah, I know.
Because I remember when I went for a DNB examination in Trivandrum, one candidate, he went on asking questions. He answered all the questions. There is nothing left for me. I think it's happening like that now. Next question is, why hypoglycemia will cause arterial ischemic stroke?
I'm not so sure why it would cause that, but maybe by any alteration in the cerebral blood flow or what. It is an association as a risk factor. I don't think it causes the stroke, but they found associations. But I can't really think of a very plausible reason for that.
Thank you very much. I think you answered all the questions. Great. Next is to, I think, Dr. SWARNA REKHA.
So you
Madam,
can
good
answer
evening.
the question.
Good
Sir,
evening,
you
good
can
evening.
answer the question. Good evening, sir. How are you?
Good evening, I am fine.
Yes, sir.
What is the role of electrophysiological studies in the evaluation of floppy infant?
If it is electromyoneurogram, I have already talked about it. I don't know if there are any other electrophysiological studies which can be done. Having said that, an EMG should be done if you're suspecting a peripheral cause of neuromuscular, unless, of course, you're very clear it is myasthenia or botulism. But there are difficulties. Again, I have mentioned this during the session that you need to sedate the baby to do interpreting it. You need to have a technician who is good enough to deal with a neonate. So there are a lot of practical problems. But yes, theoretically, there is a role of EMG in neonate presenting with hypotonia.
You already answered this question in your presentation. Common metabolic disorder presenting with severe hypotonia. And I will say it pass. Next is, what are the indicators of hypotonic baby? That is, how early can you diagnose cerebral palsy?
All right. I am not dealt with cerebral palsy at all because I just mentioned that as a cause of hypotonia in the neonatal period. But I think that is a totally different thing that we need to answer. Can you just repeat it? I will still try and answer it, sir. So what was the question? Cerebral palsy?
Yeah, the question is, how early can you diagnose cerebral palsy?
Okay. I think you cannot diagnose cerebral palsy in the neonatal period. Definitely. You need to wait for at least 1 year, or some people say even 2 years before you make a diagnosis of cerebral palsy, because there are a lot of ups and downs. A lot of them may be transient abnormalities. So you certainly cannot make it in the neonatal period or even in the first year of life. You can only say delay in development, but I don't think you can make a diagnosis of cerebral palsy.
Can I answer this question a little more?
Sure, sir, please.
Yeah.
That's why I was happy to see you here.
Yeah, sure. Still, one can make a diagnosis, because these are what you call early markers of cerebral palsy. So any baby with an incessant cry, you don't see any cause, think of cerebral palsy, and you follow it up. Any change in the tone, think of cerebral palsy, then you follow it up. And any baby with a high risk problem, you must always follow up. And the baby with excessive crying already is told. And if the baby has got some unusual postures, especially hypertonia or hypotonia, one can still make a diagnosis as early as even 2 months, because in the newborn period may be a little difficult, but you can still make the diagnosis. Next question is...
Before that, thank you for that, but I was only answering it very technically, saying, yes, you suspect this baby has got cerebral palsy.
Sure.
Because we keep teaching our postgraduates, do not make a diagnosis of cerebral palsy till the baby is
correct. You should always follow up and...
Yeah. I entirely agree with you that you can pick up. In fact, there are a lot of early markers, which sir has already said, including feeding difficulties, including excessive eating. Okay, thank you, sir. Thanks for answering that.
Next is, what are the advice given to the parent of SMA and how to counsel? Danger signs.
All right. Do you really want me to go through that?
Probably you can make it short. You already said.
All right. No. I'll say so. I think the most important thing is, have we confirmed the diagnosis or are we suspecting it? So I reiterated earlier that we need to confirm the diagnosis. And once we have confirmed that this is SMA, I think it is important to prognosticate. Again, is it SMA1? In the neonatal period, you're going to be seeing SMA1 and not the other types, because those present much later. So you need to say that this baby is going to have problems. It'll have respiratory difficulty. It'll have feeding difficulty. It'll have recurrent aspirations. It may not survive too long. And maybe with the current newer therapies which are available, I don't think there is enough evidence to say how much longer these babies live. These are all still in the early phases. I don't think it's possible practically in the current scenario to say we can offer this therapy to everybody. So we need to really be careful as to whom we are offering it. I just mentioned that free therapy is available. I think that's very good. But how long can we give this free therapy? Obviously, this is going to be a lifelong treatment. The same problem with LSDs and other storage disorders. You can get free therapy, but can the family and can the healthcare people support these babies for lifelong? So therefore, it's not very easy. I mean, I've given a theoretical thing saying, yes, there are therapies available. So we need to say, yes, there are therapies, but it's going to be lifelong. The second more important thing that needs to be told is that we need to look for support these babies, occupational therapy, physiotherapy. How do you feed these babies? How do you position these babies? How do you prevent contractures? These are the things that we need to counsel. And ideally, it should be a multidisciplinary counseling because this involves the neurologist, the geneticist, because we also need to talk about subsequent children. Can we do a carrier screening? Can we do an antenatal diagnosis? So a lot of things are there in counseling.
Thank you very much. I think next question is, how does examination of parents help in the diagnosis of congenital myotonic dystrophy?
You can get the typical sign of when there is a grip. The release in grip is a problem which could be present in the adult, but beyond that, I don't know anything else. And the second thing is even myasthenia. I think it's important because you can have myasthenia, you can make out in the parents or in the mother, and therefore examining a mother is important. Again, this must be a postgraduate because somebody must have asked them a question in the examination.
Could be. Now, next is precautions to be taken. Precautions to be taken during anesthesia in case of suspected neuromuscular disorder. You want to answer the question or you want to refer to the anesthetist?
No, sir, I won't refer. If at all, I'll refer to you. But I think it's a very important, very practical question. I think these babies are likely to have problems and therefore we need to have a ventilatory support available for these babies. There may be some medications I can't remember offhand, but yes, your aminoglycosides you don't want to use, but I really don't know about any anesthetic medications which are not allowed to be given. I think somebody else in the group can answer that question.
I think next question is muscle ultrasound and EMG correlation for evaluation of floppy infant. Is there anything like that?
Muscle ultrasound and?
Muscle ultrasound and EMG. EMG-CO. EMG-CO relation for evaluation of floppy infant.
I have mentioned about muscle ultrasound and muscle MRI, which are becoming, I would still say that it is more for research purposes, but possibly it'll move on to routine use also, because ultrasound and MRI can tell us which muscle is affected, atrophied, and I think the more practical one would be when you want to do a muscle biopsy, you can choose it by doing an ultrasound on an MRI. But I don't know this correlation, whatever is being asked. I'm not very sure about it.
So one more question to you. Any data on clopidogrel?
Not aware.
Not aware. I don't know. Does thiamine deficiency present as hypotonia?
Yes, it does. I think Asha had sent a message about thiamine deficiency. Yes, very, very can present with hypotonia, but the more important presentation is cardiomyopathy. But yes, they can present as hypotonia.
It's a question to Dr. UMESH VAIDYA. Dr. UMESH? Dr. UMESH?
I think he's not...
he is not available. Huh?
He joined back. He had a power failure. Sir, Vaidya sir, are you there?
Okay, question is, a baby with hyponatremic dehydration had CSVT. Baby improved clinically, feeding well, no there's no asymmetrical movements. Role of heparin. I don't think there is any role. Probably Dr. Vaidya can answer that question. When I talk about hypernatremia, it comes to my mind a couple of babies whom we are seeing, what we call breastfeeding jaundice. These babies, because of insufficient breast milk, they go for severe dehydration, hypernatremia, and arterial strokes and venous strokes. This is again a very important thing one may have to remember. I think there are some papers, I think one of the papers from Dr. SWARNA REKHA itself, if I remember correctly, in Indian pediatrics. But there is no role probably for this. Yeah, Dr. Vaidya has come. Can I repeat this question to Dr. Vaidya again? Baby with hypernatremic dehydration had CSVT. Baby improved clinically, feeding well, no asymmetrical movements. Is there any role for heparin?
Sir, unmute yourself, sir. Unmute yourself, sir. Unmute. UMESH VAIDYA, sir.
Yeah. Can you hear me now? Yeah. So in this venous thrombosis, it all depends on the imaging. A large thrombus associated with infarction, one may think of actually doing anticoagulation. But a child who is otherwise fairly asymptomatic, thrombosis is not very large, there is a known cause for the thrombosis, one can hold back the heparin because anyway there is no strong evidence in its favor.
Can I ask a question, Dr. Vaidya?
Yeah.
If this is a case of hypernatremic type of dehydration, basically due to insufficient breast milk and dehydration, is there any role for the heparin? Low molecular weight.
Trying to say that one, there is a clear cause. Secondly, if the thrombosis is not very large, child is not severely symptomatic, this particular child one can do without anticoagulation. Because as I showed even the meta-analysis that there is no strong evidence in its favor and it does not really change the mortality. However, people have advised periodic imaging every 5 to 7 days. If you find that a thrombus is propagating, then one may be in favor of using low molecular weight heparin.
Umesh, one more question to you.
Yeah.
From Dr. Karthik Nagesh. In CSVT, if there is associated hemorrhage, when would you they suggest using anticoagulants? Yeah.
So we saw that 1/3 of those patients who have a synovenous thrombosis, 1/3 of them have associated bleeding. So it was thought once that especially you should use heparin when there is no hemorrhage. But the data shows otherwise. The data shows whether you have ICH or not, heparin does not really make any change. And those babies who had a bleed also, the bleeds did not extend after using heparin. So again, whether there is hemorrhage or no hemorrhage, heparin has not really shown great benefits.
I think that's all the questions. I would like to make a comment toward the end, saying that both the presentations are excellent, and it should have been the theme. It should have been the theme.
Can I ask?
Sir, there are few people who have raised hands. They are requesting, can they ask the question?
Yeah, sure.
Can I ask, sir?
Yes, sir. Yes, sir. Yes, sir. Go ahead, sir.
Can we prevent, to some extent, the cerebral strokes in the newborn? Can we prevent?
Yeah. Now the prevention of stroke in the newborn is only if by doing things like removing the catheters, using kind of anticoagulation therapy when you do cardiac procedures, ECMO, catheterization. Those would be preventing sort of dehydration. Those would be the indications, the way of preventing stroke. Of course, people have tried antithrombotic therapies in mothers with thrombophilia, but the data is very few to see whether they actually change the outcomes in the mother or the baby.
Sir, does the incidence of stroke vary with the normal delivery, cesarean delivery, and the breech deliveries?
In fact, they have shown that the cesarean delivery is more associated with neonatal stroke. And the reason for that is that most of these mothers could be thrombophilic. They have placental abnormalities that lead to abnormal partograms, and that is why these people are subjected to cesarean sections. So surprisingly, strokes are more associated with cesarean deliveries rather than the vaginal deliveries.
Sir, can pyridoxine can cause hypotonia in the neonatal period? Pyridoxine deficiencies.
Pyridoxine.
Pyridoxine deficiency can cause hypotonia.
I am not very sure about it because pyridoxine we usually associate with seizures. I don't think so, but I'm not very certain about it. But again, a lot of these vitamins and trace elements, their deficiency can cause problems. But I haven't come across any case report or anything which says pyridoxine deficiency specifically presents with neonatal hypotonia. I'm not sure about it.
Can we clinically differentiate between the neurological cause from non-neurological cause of hypotonia?
When you're saying neurological, you're saying, are you looking at acute illness versus neurological? I presume that's what you're telling. I don't think we can clinically differentiate because a neonate who has got hypokalemia or a hyperkalemia having a tonal abnormality is not going to be any different from a central hypotonia. The only thing is that it's going to be milder and it's going to recover with treatment. But apart from that, there is no clinical differentiation to say that this is non-neurological. And when I say non-neurological, because even your metabolic disorders are ultimately neurological. So all the causes that I listed under central and under peripheral will become a neuromuscular, but I'm only separating out acute illness and I don't think you can clinically differentiate. But if you're asking me, can we differentiate central causes, which I have already mentioned, that is your syndromes, your metabolic disorders, asphyxia-related, neuronal migration syndromes. So all these central causes can be differentiated from the peripheral. And if you go back to the slides, there is a table which shows the differences between central and peripheral causes of hypotonia.
How we should manage a sedated baby, hypotonic, sedated for the eclampsia? Mother who is eclamptic and has gone under sedation.
Okay, now, see, there are two things to your question. When you're saying a eclamptic mother, the first thing I would like to know is actually receive any magnesium. Now, the sedation of the mother is not going to really affect the baby because whatever sedation they use or whatever medications they use are going to be quite safe for the neonate. So in terms of breastfeeding, there is no problem. If it is not magnesium related, I don't think there is any different way that you're going to manage the baby. But if such a baby has got a respiratory depression or you find that this baby is having slight tonal abnormality or requiring a little oxygen, I think you need to keep in mind magnesium, do a magnesium level and give calcium to reverse this issue.
Sir, madam, is there any current medicine for the Duchenne muscular dystrophy?
For what? For Duchenne. Yeah, Duchenne, again, see, dystrophin, there are a lot of work which is going on about it. Again, the deficiency there is dystrophin. So they're looking at replacing that. They're looking at genetic. But I don't know, I'm not aware if this is available easily, but I think it's similar to what I talked about SMA. There are some medications which are being tried and which are going to be very expensive. And a lot of them are on a research mode and it may be available.
Okay.
Because
thank you very much.
Cause, so therefore, it is possible to give these treatment.
Thank you very much, madam.
Thank you.
Can I make a comment?
Yes,
sir.
Yeah,
Yes, sir.
I think Dr. Rekha has emphasized so much on the clinical medicine. I think this is a very nice thing to take home. I can only say simply by saying that she has said all that. See whether the baby is sick or it is looking well. If the baby is sick, she has put everything on acute problems like septicemia and so on. If the baby is not sick, think of the rest of the problems as a peripheral problems. Next important thing what I feel that you must look for is the reflexes. If the reflexes are brisk, it's definitely you can rule out all the peripheral causes. Is a more of a central cause, like going to be cerebral palsy. Somebody asked a question, it can be an early sign of cerebral palsy. And if the reflexes are sluggish, it can myopathy. If the reflex is totally absent, it can still be a myopathy and probably still a Werding, the conditions like Werding-Hoffmann disease. I think this is only, I felt it a practical bedside diagnosis of a floppy infant. Of course, next is the most important thing is you look at the child's face. Does it belong to any syndromic malformations? If it is not syndromic, the syndromic malformation, what all I said, reflexes are more important. And Dr. Vaidya, I think you have done an excellent job. It's very crisp. And I can only say that Dr. Gowda could have given the name for this particular webinar as brisk and clarity. That is, I think, probably the theme of this webinar. Thank you, Dr. Prashant Gowda. I think I would like to say that I would like to congratulate all of you for keeping up this good webinars. And I've been a very silent, listener to this webinar, except in the last probably 1 week. I missed a couple of them. Otherwise, excellent thing going on. All the best.
Thank you, sir. Thank you, sir. Kodreshi, sir.
Sir, I am very thankful for on behalf of Karnataka NNF to the Dr. SWARNA REKHA BHAT, Dr. Maya, and Dr. Kishore Kumar, and you, and Dr. Vaidya also. Very good topic they have been given this today, and we need blessing all the seniors, Dr. Maya and Dr. SWARNA REKHA BHAT and Dr. Vaidya. Well, thank you, sir. Thank you, Anand.
Thank you, sir. Thank you, sir. It's indeed a very pleasure to hear, ma'am. Thank you very much. And I'm a very big fan of you. Thank you very much, ma'am. And sir, I'm a very, very big fan of you as well. And I've personally spoken with you as well. So it's a wonderful piece of information what we have collected today. It's going to help. Already YouTube, it's breaking the record. In a month, we had more than 1,000 views from the time we have put all the recorded videos of our excellent speakers. So if somebody has missed it, we are going to upload in Facebook, NNF Karnataka page and YouTube page. Please subscribe, press the bell button like how they advertise. So we are coming up this entire week. We're going to have neonatal urology chapter. So the upcoming day after tomorrow, we're going to have session on intraventricular hemorrhage and periventricular leukomalacia, prevention, treatment, follow-up and complete management, and ultrasound, role of ultrasound in PVL and IVH, how to differentiate. I would like to thank SWARNA REKHA BHAT Madam, Maya Sir, UMESH VAIDYA Sir once again on behalf of NNF Karnataka, President, Vice President, Secretary, Joint Secretaries, and the EB members and the entire NNF Karnataka group. Thank you very much, sir. Have a very good evening. Thank you. Bye, 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 sir. Bye, sir. Bye, sir. Bye, sir.